Welcome to the Stanford Clinical Lecture Series in Radiation Oncology. This year we will have 22 lectures given by radiation oncologists, dosimetrists, and physicists. The lectures will be twice a week on Wednesdays and Fridays at noon for Stanford attendees and at 10 p.m. For Ukrainians. And they will span from September to November. We also invited Ukrainian radiation oncologists, medical physicists, and RTTs to participate this year. So, доброго вечора вам з України і слава Україні. Our Stanford physicians can apply for Stanford CME credits. So here's the tax number to get the credits. I'll also post it in the chat. Ukrainian audience will get the certificate of completion with the number of credits equivalent to a number of attended lectures. We will record these lectures and translate them into Ukrainian and post them on our website. And to make the lecture more interactive, we'll have the questions popping up throughout the lecture. So pay attention, listen up. So our first topic today is radiotherapy for GBM, and our speakers are Dr. Soltis and Dr. Pham. Dr. Soltis is a professor of Stanford Radiation Oncology and Neurosurgery. He is also a recent fellow of ASTRO and a renowned CNS radiation oncologist in the world. His clinical and research interests are brain tumors, radiosurgery, and spinal tumors, and many others. He was also a Stanford resident at some point and then became a Stanford residency director. He's a great teacher and recipient of many teaching awards, notably ARO Best Teacher of the Year Award. And another speaker is Dr. Daniel Pham, and he's an amazing dosimetrist with a PhD. He's originally from Australia, so that's where the accent comes from. And Daniel used to work at Varian, and now we are very lucky to have him here at Stanford. So he will be teaching us at the end of the lecture on the treatment planning for GBM. So, but first we'll start with the clinical aspects of GBM. Dr. Soltis, please take it away. I'll start sharing.
Great. Yeah, thank you for that kind introduction. You can see my screen, I think. So if not, just let me know if you can't hear me, text me or something.
Looks good.
Okay, great. Thank you. So Daniel and I were asked to speak about gliioblastoma, which I will abbreviate as GBM. And knowing that this is a mixed audience, I'll have a pretty high level overview of GBM, but then certain topics I will dive into a little bit more detail about why we do what we do as radiation oncologists. Okay, these are my disclosures, and one thing that we'll touch on is Novocure is providing some research funding for a trial that I have in patients in GBM. They make the device tumor treating fields, and we'll be talking about that. So let's start with a common patient. This is a 60-year-old woman. She presents with headaches for a month and nausea and vomiting for 1 week, but otherwise she has a good performance status. And then after history and physical, the first thing we'll want to know in my clinic is, what does the MRI look like? And for basic review, here are the main sequences we may look at. This is the T1. Well, let's start with T1 pre-contrast. So this is, you just put the patient in the scanner and don't do anything, and this is what you get. If you add IV contrast, so gadolinium, then parts of the brain, parts of the tumor may start to enhance. So this is post-gadolinium. And it shows a tumor. And then you can get your T2 weighted images. So T2 shows fluid as bright, so it's hyper intense. So that can either be cerebrospinal fluid in the ventricle here, so this is normal, or it could be fluid within the brain, so-called like interstitial fluid. So this is fluid around the cells, or fluid within kind of a cyst of this tumor. And then the difference between T2 and T2 flare is that the flare attempts to suppress free fluid. So the fluid in the ventricle is freely floating around so that it becomes dark. The cyst becomes darker, but then the interstitial fluid that's not free, it's in the cell, between the cells of the tissue, remains. So that's T2 flare. So this shows a tumor. Ultimately, she has surgery, and this is what the pathologist shows in tumor board. This is histology, so simply what the tumor looks like under the microscope. And that leads to kind of our talk. So this is where we're going over these next about 40 minutes. And we'll touch on each of these. And this is the same outline for every lecture during this series. So let's begin with brain tumor classification. Knowing that there are some residents on here, I will go into a little bit more detail because you need to know what a tumor is before you know how to treat it. So let's go into that. Looking only at the slide, the H&E, the histology, we used to classify tumors. This was the only way that we had to classify tumors, and we used the so-called AMEN criteria. So that stands for, yeah, there we go. Atypia, so atypical cells, they don't look normal, or nuclear atypia. And then if you have rapidly growing cells, you could recall back to basic biology that when a cell grows, when it divides, it forms a mitotic figure. So if you see that in the brain, where your brain is usually not growing, then that's a tumor that's growing, so mitotic figures. If you have growing cells and growing tumors, they need blood supply, so you get endothelial proliferation. So blood vessels are made of endothelium, so you see more of that. And in a rapidly growing tumor, they outgrow their blood supply. They're growing so fast that they don't get enough oxygen, don't get enough blood, and they start to die and they form necrosis. So as you see more and more of this, it becomes higher and higher grade. And you may read some old papers that had this classification. So if you had a grade 2 tumor, and the two main histologies in the brain are astrocytomas and oligodendrogliomas. If you only had some abnormality, those were so-called low-grade gliomas, grade 2s. If you start to have some mitotic figures and more atypia, that became grade 3. And then if you had all of the so-called AMEN criteria, that was grade 4. Or not necessarily all, but if you have necrosis, proliferation, then that made you grade 4. These kind of go together. So by histology, this is a grade 4. This is GBM. Here, I don't know if you can see my pointer. Here's a mitotic figure with the chromosomes lined up. This is some blood vessels with some blood cells in it. So this is endothelial proliferation. This is an area where you don't see cells. This is an area of necrosis. And in GBM specifically, it's so-called pseudopalisading necrosis. So basically, tumor cells fleeing an area of low oxygen, and they're palisading away from the necrosis. So this is GBM histologically. If you look at old reports or old textbooks, this is how brain tumors were, or brain gliomas were characterized. So so-called low-grade gliomas, grade 2s, and high-grade glioma 3s and 4s. But this was problematic because if you looked at the survival curves, the GBM was the only one that separated out from the rest of the gliomas, but you had, some 2s that did worse than 3s, some 3s that did better than 2s. So this wasn't too helpful. So that's why in 2016, they started to add molecular features to histology. So in addition to just looking at the slide under the microscope, we started to stain for specific molecular features. And the main ones at this time were IDH mutation. So if you're IDH mutant, you're typically a lower grade glioma. And if you were GBM, you were typically IDH not mutant or IDH wild type. One thing to note is, unfortunately for any glioma, even a lower grade, grade 2, it's not thought that these tumors are curable. And if you're going through this lecture series and you look at survival curves for other, tumors, lung cancer, breast cancer, head and neck cancer, you'll often see this curve plateau where it becomes flat. And that plateau means those people are likely cured. Unfortunately, some of these curves continue to go down, even though survival is measured in decades for some of the lower grade gliomas. I mention that because that impacts how aggressively we treat patients with a brain tumor. So the World Health Organization every 5 to 10 years has a new classification of brain tumors. The one I just showed you was 2016, and then we just had one a couple of years ago. And some of the changes over the years, some are just stylistic, like it used to be called gliioblastoma multiforme, but they dropped the multiforme in 2016. So now formally it's just glioblastoma, but we still generally just call it GBM. I already mentioned in 2016, we started to add IDH status. If you're 1p19q co-deleted, you are an oligodendroglioma. It's kind of a different talk altogether. And then the big change in 2021, just a few years ago, is that they tried to simplify things. And the main simplification is that it all starts with your IDH mutation status. If you are IDH mutant, in general, that means you're not a GBM. And in general, that means you're a grade 2 or 3 glioma. And therefore, if you are IDH wild type, you are GBM, or the only way you can be GBM, have a GBM, is to be IDH wild type. So you may want to remember that. So what this looks like over the years, the other change they did to stylistically be the same with other cancers is they changed Roman numerals to Arabic numbers. So it's not Roman numeral anymore. It's 2s and 3s. So IDH mutants are still IDH mutants, grade 2 and 3. What we used to call a grade 2 or 3, but IDH wild type is now GBM. If you're IDH wild type, you're GBM. What we used to have so-called IDH mutant GBM, and they made a new classification of that. So it's now IDH mutant grade 4, and then old GBM is still GBM. So you can see they tried to simplify it, that the only way you can diagnose the GBM is if you're IDH wild type. If you have an IDH mutation, you cannot be called GBM. There are various glioma guidelines that attempt to show this in other ways. So again, old criteria with no molecular features. In 2016, we started to add IDH and 1p19q. But even at this time, there were kind of 2 ways to get to GBM, and they simplified that to only this way. If you're IDH wild type, you are GBM. And yet another way, again, it all starts with IDH. So IDH wild type is the only way to get to GBM. So that brings to our first question break and my first water break. Which of the following is correct? Oh, thanks, not today. In 2023. So I'm not sure how this works.
Yeah, so we will wait for enough answers. So I guess 46 people, 50 people now. So I can end the poll.
Yeah.
Share results.
Yeah, okay, great. So the only ways to get to IDH. Also, you see, it's hard to write a good question, and this is honestly not too good of a question. You know, it comes down to something probably with IDH status. So 4 choices turn into 2. And well, maybe this, we no longer use Roman numerals. Okay.
That's a good one.
Okay. And then this is the master grid that the residents know to put by their bedside and stare at and memorize for gliomas. But you can see if you're IDH wild type, you are GBM either histologically with AMIN criteria, or there's a way to get there molecularly, and I didn't go into that. And then all of these are IDH mutants. Okay, so with that kind of more deeper dive, let's have some very basic epidemiology and anatomy. And anytime you think of brain tumor epidemiology, you just pull up this paper that's updated every year. This is CB Trust, or the Central Brain Tumor Registry of the United States. And they have a lot of good figures in here. So I just picked out some of the highlights of this. So red are primary brain and other CNS tumors, but that's largely brain cancer. So you can see in children, brain tumors are the most common cancer, more than leukemias here. As you get older, then breast cancer becomes more prevalent, and then even older, 40 plus, then men with prostate cancer, women largely with breast cancer, and then you've had decades of smoking to lead to lung cancer. And brain tumors become less and less common, and in general, as far as cancers go, they are uncommon. Within all primary brain tumors, most of them are benign. So blue are all benign tumors, and most of these are meningiomas. So the most common primary brain tumor is meningioma. The most common malignant brain tumor or brain cancer is GBM. The most common tumor in the brain is a metastasis. So these are, well, the number of brain metastases is a little bit higher than the overall incidence of breast or prostate cancer. So if you look at brain mets, it'd be way up here. In general, men are more likely to get brain tumors. You can see that. For benign tumors, meningiomas are much more common in women, and that's largely because they have estrogen receptor, progesterone receptors on the tumors. Postmenopausal women have the same incidence of meningiomas as men. And then looking at overview of anatomy, most gliomas are in the supratentorial brain, meaning above the tentorium. So essentially not the brainstem, not the cerebellum, not the spinal cord. So you can see that that's frontal lobe, temporal lobe, parietal lobe, cerebrum, whatever that means. And you can see the gliomas in the brainstem and spinal cord are pretty rare. And amongst all gliomas, GBM is the most common, so 59%. If you do the numbers here, 59% of 21,000, that's about 13,000 cases per year. As far as symptoms, one helpful way is to contrast a so-called lower grade glioma, grade 2 or 3, with a GBM or higher grade glioma. And in general, those with lower grade gliomas, they grow slowly. So patients, in retrospect, they realize, oh, well, yeah, maybe I've had some symptoms from this tumor over months or years. Lower grade gliomas are more likely to present with a seizure than GBM. And that's because patients with GBM are more likely to present with symptoms of mass effect, meaning that the tumor is growing rapidly enough that it causes symptoms of pressure in the brain, which are largely headache, nausea, vomiting, or weakness. Patients with GBM do have seizures, but it's just less common than those with lower grade gliomas. Following the standard outline here, staging, that's easy in CNS because there is none. So we have grading, WHO grade 2, 3, 4, 1 is grade 1s, we're not talking about that. But there's no staging. There's not a tumor node metastasis staging. Gliomas usually don't metastasize out of the brain. So it's when a tumor comes back, it's still largely within the brain. And now let's go into treatment. And the main options for any cancer are surgery, radiation, chemotherapy, and now a new agent, tumor treating fields, which first became indicated in GBM, but now there are multiple trials for TTF or tumor treating fields elsewhere in the body. So let's start with surgery. What is the role of surgery? The main role is to get a diagnosis, like what is this tumor that you see? But the second main goal is to have a so-called maximum safe resection. So you should try to resect as much tumor as possible without causing a neurologic deficit. So the neurosurgeon could certainly resect it all, just keep taking more and more tumor out, but that could lead to post-resection deficits. And recall that for the most part, these tumors are not thought to be curable, so you have to balance how aggressive you are. Like a correlate, like say you had a head and neck cancer with tumor near the eye, in that situation, you may give full dose to the tumor to try to cure it, but you would risk blindness. And the risk balance ratio of that's a little bit different than in a tumor that like a brain tumor. So what are the data for extensive resection? They kind of goes back over many years, but in general, the more that you can get out, the better the survival, even down to a partial resection, even just like 70% resected. So another way to look at that is if you have many, many trials, you can analyze them all in a so-called meta-analysis. And in general, once you plot the data points on this relative risk line, you can see where all the data fall. And as a whole, if it's to the left side of this line, then that favors gross total resection. So this meta-analysis is positive for a benefit to gross total resection. I'll show a similar meta-analysis curve later. If it's on one, that means there's no clear advantage one way or the other. But here there's a clear advantage to gross total resection. Okay, so now that you've had a maximum safe resection. What is the standard treatment with radiation and chemo? So why do we do radiation at all? It stems from this trial from 1969. Patients with so-called high-grade gliomas. So back then, this would have been grade 3s and 4s, oligos or astros or GBM, all mixed up. But it shows that the two arms that had radiation had a better survival. And at this time, the radiation was whole brain radiation. And we'll talk about that. Another finding is it wasn't clear that chemo did much of anything. So if you do chemo alone, it's not much different than best supportive care. If you add chemo to radiation, it doesn't look to be better. Also, unfortunately, this was the only positive trial for almost 25 years until our current standard of care, the STUP regimen. So this is 1978, and the next, basically the main next positive trial wasn't until 2005. This is the so-called, this is a so-called STUP regimen, radiation alone, which was the standard of care at the time, versus radiation plus concurrent Timidar, and then adjuvant Timidar for 6 months. Timidar, temozolomide, is a chemotherapy pill that you take each day during the radiation. It's generally well tolerated. And the benefit of adding Timidar, there's kind of a modest benefit in the median overall survival. But the real benefit appears to be in the kind of long-term survivors, where you have a clear separation out 2, 3, 4, 5 years. This is evolving and a little controversial, but it appears that most of the benefit of Timidar may be in those that are have the molecular feature of hypermethylation of the promoter of the MGMT gene. That said, even if you're not MGMT hypermethylated, most places still will add Timidar, and we're still kind of looking into how to personalize treatment based on MGMT status. Okay, so that is the current standard of care, concurrent and adjuvant Timidar, until TTF was evolved. So tumor treating fields, or TTF, is, honestly, when this first came out, everyone was skeptical. It's just putting an electromagnet on your head and connecting it to a battery. And the rationale behind this is that when a tumor divides, again, thinking back to basic biology, from one tumor to turn into 2 tumors, the chromosomes light up, they start to split, and this cleavage, the mitotic spindle, becomes polarized. There's a magnetic dipole here, where some ends are positive, some are negative, and this tumor treating fields messes up the magnetic dipole such that the tumor cannot divide, and it kind of gets stuck in this telophase phase, and then it dies. So your brain is not dividing, but tumor cells are. So that was the rationale for using it, or inventing it. It was approved based on this trial. So these are in patients that have a GBM that has come back, has grown back after standard treatment, and they were randomized to either next best chemotherapy, like almost whatever the neuro-oncologist wanted to give, versus this magnetic device. And you can see there was no difference in outcomes. It wasn't that TTF was better, it's just that it wasn't worse, or it was equally effective, or some would have said equally ineffective. So if this were a drug, some said that probably would not have been approved, but it's not a drug, it's the device. So it's a different pathway through the FDA. So it was approved through this trial. And people were still, kind of skeptical about the outcomes. But since it was approved, then they STUP ran a second trial where you added TTF adjuvantly after standard chemo-RT. And this was surprising to a lot of people, a positive trial. And the benefit of adding TTF was the same as adding Temodar to radiation alone. So the hazard ratio of these two curves are the same compared to the original STUP trial. And there are some subtleties or nuances to this trial that I won't get into right now. Oh, and one other thing is the benefit for TTF is independent of MGMT status. Everyone had the same kind of hazard ratio of benefit. So when I see a patient, it's often, we say the best survival outcomes are adding TTF, but it's also a quality of life issue. Some people look at it and they say, yeah, I'm interested in wearing it. I'm already going to have a little bit of hair loss from the radiation anyway, so let's give it a try. Other people look at it and they say, I don't want to shave my head. That's a big quality of life issue for me, so I'm not going to do it. So it's, that's generally what the discussion is with the patient. So let's go to this patient. She's a 55-year-old woman. She has a maximum safe resection of a right frontal tumor that turns out to be GBM. And she asked what treatment is associated, what treatment paradigm is associated with the best survival outcomes. And I get another water break. So question number 2. Okay, great, thank you. Yeah. So now some of the more detailed points. So in patients with newly diagnosed GBM, when should they treat? You have a potentially, aggressive tumor. So is it better to start them 1 week after radiation, like right away, or 2 weeks or 3 weeks? Well, overall, the weight of the data, and there are a lot of data, says it doesn't matter. In general, we try to start within 6 weeks, but even then there are studies that look at before and after 6 weeks, and there's no difference in outcomes. So again, this is a meta-analysis of many patients, many studies, and unlike that prior meta-analysis, which was clearly on one side of the line, these are all right down the middle. So there's no evidence that a delay of radiation impacts survival. That said, we generally try to get things started within 6 weeks, but patients certainly have time. I reassure them they need to make, if they're considering clinical trials, they have time to fully explore that and make a decision. Okay, what dose do we use and why? These are old brain tumor study group trials that showed, in general, looks like more dose the better, up to 60 gray. So if more dose is better, why don't we try something higher than 60 gray? Well, RTOG tried that in the 90s. They had 60 gray with or without dose escalation with radiosurgery. And there was no improvement in survival with the addition of more dose. So there's no benefit to radiosurgery. There's really no standard use of radiosurgery in patients with newly diagnosed GBM. This was the pre-temozolomide era. So in the temozolomide era, R2G is now energy. This is the current trial that's open, and dose escalation in a like SIB technique, so 75 gray and 30 fractions. The preliminary results were presented last year at Astro, and unfortunately there was no benefit at that time with higher dose. But we await, for your full results. So that's dose 60 gray, the standard. What margins are used and why? Well, those early trials I showed you used whole brain radiation, and that was because this is a kind of a more recent biopsy series, but if you biopsy what looks to be tumor, you get tumor cells. If you biopsy edema, T2 edema, you get tumor cells. But if you biopsy normal brain, kind of on the other side of the brain, perhaps, you still see tumor cells. So that's the problem with any glioma. They're tumor cells that extend. It's basically a gradient of tumor beyond what you see on MRI. There's, so-called Kelly series of biopsies where you had tumor, and if you biopsied like 4 centimeters away, you could still kind of culture and identify tumor cells. So that's why we did whole brain radiation, just make sure you don't miss. But over the years, they saw that if you do whole brain radiation, the tumor usually recurs most of the time, within 2 centimeters of the MRI scan. If you did whole brain radiation, it's still usually within 2 centimeters. If you did a smaller field, is within 2 centimeters. So there wasn't any difference in patterns of progression. And then we actually have some randomized trials that are small that show there's no difference in survival between whole brain and something not whole brain. So we don't do whole brain radiation anymore. There are 2 main camps for treatment, and it's generally if you're one to cover T2 edema, that's what R2G or energy does. So kind of a lower dose to a big field, and then you come down to just the cavity and enhancing tumor. Or you can be like the EORTC, like the STUP volumes, where you don't purposely treat T2 tumor. And here's what I do. But perhaps the best kind of thought behind modern volumes is this paper that just came out within this last month. This is an update of an older estro guideline, but GTV is the tumor and cavity, so that's this red line. CTV is an expansion, and one thing they changed in this guideline is they used to say 20 millimeters, but they are now recommending smaller margins, so 15 millimeters. So that's this blue line. CTV, you can crop at anatomic boundaries. So your CTV is not going to go into bone. It's not going to go across falx, but you have to make sure you don't crop it at corpus callosum. Right? T2 edema is not included in your volume. So in this example, they say, this is not tumor, it's just edema. We don't need to purposely cover it. Whereas R2G, the volume would be like way back here. It'd be edema plus 2 to 3 centimeters. Another example from this paper is here, where you don't cover T2 edema, but you cover T2 signal that is suspicious for tumor. So here's clear tumor enhancing, but you have this tumor doing what they can do, which is cross over the corpus callosum. So include that, and then add a margin, and then all this goes to 60. And there's kind of basically margins are not standardized. Dose is standardized, that's 60 gray, but how you get to 60 is not standard. No, I will skip through some of this and just get to once we have our volumes, what are some dose constraints. Again, here's the old Estro guideline. And I tend to do these except for a few exceptions. So like cochlea, I will undercover an arbitrary CTV in order to not cause deafness on one side. So my cochlear constraints are usually lower than that. But basically I don't give it, certainly don't give it 60. I give it, 40 just to make sure they don't have hearing loss. And I think all the rest of these are pretty safe. One thing I add is, permanent alopecia is entirely preventable with, VMAT techniques. And it's, a huge quality of life if they're going to have permanent alopecia for the rest of their life. And it's an easy push. So if you don't put a constraint on a VMAT plan, this is what you may get. But if you just set scalp or skin as the body contour minus 4 millimeters and just keep that under 38, then they never have permanent alopecia. Hair starts growing back like 3 months later. Okay, yeah, one question and then I'll hand it off to Daniel. So just question writing, if you see always, always, or must, then you kind of know that's not the right answer because there's nothing in medicine that's an always. So the answer here, and I think we'll get that, the dose is 60 gray, but how you get to that dose is debatable. Okay, real quick, like patients coming here, there are chemotherapy trials, and then here are the non-chemo trials. We have Trident open here. So if TTF appears to work in the adjuvant setting, why not move it up front where there may be some synergy with concurrent radiation? So this trial, patients are randomized. I have a similar trial where we had a 1 week protocol, and now I'm doing 1 week plus concurrent TTF. One thing for the therapist, they may see patients come through. So at the time of SIM, if you're on this trial, you wear TTF during radiation, so you need to have a pad to give them space to have. So that's why through SIMs, you may see us come by and like build this little padding around their head. Okay, this is where we went. We kind of went through all this. So thank you for your attention. And then